giving you a lot of the formal definitions and the nuts and bolts of how all of this works. And I am going to just take a little personal experience and give you some insight into care coordination from my perspective and my family's. And a lot of this I've addressed over the years in my work with the Secretary's Advisory Committee for Heritable Disorders in Newborns and Children, and through work groups, through NIMAC and so forth. We address the medical home and what care coordination is about and so forth. So it's really great to always be able to bring that parent perspective in with the professionals, because the reality is it looks different from the professional side and the family side. And you both have the ultimate goal in hand, is to make sure that a patient has the appropriate and effective care. But healthcare is complex, and sometimes those perceptions differ, and it's great to be able to come back and bring that patient perspective into play and say, no, this is really what it means to us. So I told you a little bit about our background with when Stephen had his episode and then Caroline came along. Same disorder, 2 different children, and our story is very similar to others. Again, these are pictures of Stephen before he got sick, plain, typical child, nothing extraordinary. Well, checkups were simple. You know, we've been fortunate to belong to a pediatric office with one physician. His wife is the nurse practitioner, and then there's another one, so he knows all his patients. All along, after Stephen got sick, I looked back at his records, and every appointment said, "Mom's concerned, picky eater, picky eater." You know, you look back, and we communicated these things, but hindsight can be really brutal because the signs were there of his condition, but because it was so rare, no one really knew. So these are Stephen's simple days, but then again, this is what we encountered 24 hours after one of those other photos. Suddenly, we realize how complex healthcare can really be. And my husband and I were both very educated in, we thought we were. I have a background in therapeutic recreation. So I, worked with a lot of children with special needs and, really felt I was prepared. I had no idea that I could ever possibly prepare myself for what was to come. As I said, Stephen was very complex at the time, and it didn't get any easier. Caroline, very simple, same disorder. She's can be difficult too. Care coordination for her can be a little different. And to give you a little perspective on care coordination, I sat down and I came up with this one night. And I tried to, in preparing my slides, I tried to give all areas of Stephen's care that have to be coordinated. And these are all the different specialists that are involved in Stephen's care, but it also involves insurance, Medicaid, they're all part of it. Rehab engineering, where we go for Stephen's wheelchair tweaks and so forth. The courts, I say the courts because Stephen turned 18 last October, and we had to spend a great deal of time going through the process for obtaining legal guardianship for Stephen before his 18th birthday. I can't even tell you what the coordinating was like for that. It was daunting, to say the least. And then after that, I have, after I submitted these, I realized, gosh, I left so many things out. I have all the specialists, the primary caregiver, the courts, Medicaid, and under Medicaid becomes all his benefits to include his Medicaid attendants. My 2 older sons are 2 of his Medicaid attendants. Then I thought about pharmacy. We have families like us don't have one pharmacy that we deal with. We have multiple pharmacies. And especially when you're dealing with a rare disease, sometimes they can't get access to the medication that you need. And somehow you have to coordinate everyone to get the physician to approve the refills or to obtain it, to find another one. So it is coordinating. And even in that process, when you look at all of these things, you would like to think that there was this streamlined process that, the prescriptions are called in from the physician's office. we get them filled, and suddenly you do the automated call, you have everything in play, you get to know the pharmacist really well, and then you get denied for refill because there's no more refills, and you find that out at midnight on a Saturday night because that's just when you had time to do it. So there is no one to authorize the refill on a Sunday, but you get through to Monday, and then sometimes it's Monday, it's Tuesday, it's Wednesday, and no one's returning the pharmacist's call or their fax to get the refill authorized. So I have to step in, the ultimate coordinator, to say, hey, can you call our pharmacy and authorize those refills? It's very typical. The best laid plans don't always work very streamlined. So I thought at pharmacy, medical supplies, we have to order and maintain a stock of medical supplies that, I could probably fill CVS with sometimes. And for somebody like Stephen, there are diapers, there are catheters. He has self-cathing because he has a neurogenic bladder. So that's another entity. Or the devices that he needs, the feeding pumps, the formula that goes with the feeding pumps, the tubes, the syringes, the extra buttons. Let me see, what else? The suction machines that you need to stay on standby, the pulse oximeter. So there's all these devices, all the medical supplies that patients like Stephen need on a daily basis. Somebody has to coordinate that as well. I also have education. That is a part of his life. And as everyone else said, as Kristen said, there's other entities of the life that I said, I think these balloons could have just kept on going. There is family, there is social life, there is the education piece or the training, depending on the child's level. Stephen, I have done homebound education for him since he was school age because it kept him healthier. He has been homeschooled lately, the last few years, but now he's going to be done. So it's a lot. Caroline, still coordinate a lot to coordinate as well, not quite as much as Stephen. She also has the specialists involved, the insurance. Education looks very different for her, but still some of the same coordinating has to occur for her that does for Stephen. And at the end of the day, this is how I feel sometimes. And I know that many parents can feel that way, especially when you get the calls or, if it's, an insurance claim, because there is a bill for Stephen where he has primary insurance and Medicaid. And so I said, there should not be any deductible. There shouldn't be any out-of-pocket expense. But then I have to put everybody together and find out why there is, only to find somebody's error or some glitch in the system. So, care coordination, if it was in a perfect world, sometimes we wouldn't feel like this. As I said, others have ran through already. Care coordination, it's an individualized process. There are no two patients that are alike, and that is where personalized medicine comes into play, where you have to address each personal individual situation as its own. And care coordination exists at different levels. We look at all of those areas of life, but then you can also take it to another level and say care coordination occurs, within facilities. You have inpatient into outpatient. You have unit to unit base. What happens when your child goes through the emergency department but has to go to the regular floor or the ICU? Somebody's got to coordinate that, and you want to make sure that all that information is connected. And then also, anything that happens inside an inpatient facility or with any of the outpatient facilities, you've got to make sure that the primary care physician is always connected. And this is where it really requires effective communication, and those electronic medical records are a saving grace in order to really make a lot of this happen. We didn't always have it. Ultimately, it does improve the health and quality of life if you can have everyone in sync together. And to speak a little about the electronic medical records, as I said, when Stephen first had his episode, we didn't have it. And so we relied on the paper trail. You should see my boxes of statements. They exist. I could have a whole other closet for them. So when Our dilemma was, at one point, was Stephen and Caroline are followed metabolically and all their specialists at Children's National in Washington, D.C. Our primary care physician is in Northern Virginia, not connected with Children's at all. And with children with a rare disease like this, sometimes you just bypass that primary care physician because you already know we're beyond going to that physician. He or she gets lost in that shuffle. And so I had to be the person always making sure that he knows I'm talking about him. Here's the story. Making sure that that primary care physician knew what was going on. And it's easy, and we've talked about this in our medical home work group, that you want to always maintain that relationship, because even though you jump to the specialists, a lot of times when kids like Stephen get sick, you want to keep up with your primary so that they really do know what's going on. And the more you can keep up with them, the more you stay linked. When Children's went with their electronic medical records, and they did inpatient, and then they went with the outpatient clinics, a little hairy at first, but you work out the glitches, it really makes life much easier. And as a parent, it makes you feel better to know that when you are in one of these specialty clinics with your child, and you know that there's all these others, and they're peers, it's really great to be able to sit there together, to pull up that record and say, yes, Dr. So-and-so did prescribe this medication, this was the diagnosis, or this is what the x-ray showed. It really helps you feel a level of trust that everyone is on the same page, because with a patient like Stephen, one little glitch in his health care can really throw him off, whether it's medication or whatever area of health issue he may be having. Stephen always challenges the system. We get one system worked out and he comes up with another one. And so those electronic medical records really help to instill effective communication and keep everybody on the same page. Medical errors are reduced because if you are relying on those paper trails, some things get lost, and it's happened with us. They also reduce the burden on the parent. As Kristen said, having a medical home, the first time one of my first meetings when I became an advocate with newborn screening, and we started talking about the medical home and care, somebody asked about, do you have a medical home? And I said, absolutely, we have a medical home. And I always tell this story. I said, yes, we have a feeding pump, we have syringes, we have all kinds of equipment at home. It's a very medical home. And they looked at me and I realized we're talking about the two different things here. And that was when I realized I'm really an amateur with this, and I don't really know what you're talking about. But like Kristen and the others learned, we understand the concept of the medical home. And basically, until people started really addressing this professional theory of a medical home, we were it. I've always said, I'm it. Yes, I am the medical home. I like being able to share the wealth and not always having to have everything fall on my shoulders, because it is a huge burden. But in a parent's defense, when you have a child like Stephen, and what I think many of us do today is because we all have these children, they're like 18 years old, I'm going to be 19 this month. It wasn't so simple when our kids were born or when they got sick like Stephen. And our goal is to hopefully it gets easier for the parents today so that they don't have to do that. So in reality, it works at different levels. But in theory, sometimes it is still the parent, and we will always still stay within the spectrum of what's going on. We are the ultimate care coordinator in many instances, and it does apply with the medical home. And I leave you with this concept: if you want effective care coordination, you want it to be the best that it can be for everyone. Is you can wish for it or you can work for it, and it's your choice of how you take the approach. So thank you.